Pablo, estás en mute.
We cannot hear you, Pablo.
Hola y muy buenos días a
Good
todos.
morning to all of you and happy 2021 to all of you. Thank you for joining us here today at PAHO on this press briefing on COVID-19. My name is Paulo Lira and I am with the Communications Department at PAHO. This press briefing will be between 45 minutes and 1 hour long. You will be able to send your questions live and also through the Q&A button. Please do include your name and media outlet when you send your questions. Please also remember that we do have interpretation into English and into Spanish. This session is also being streamed live on YouTube, Facebook, and Twitter for more of you to be able to listen to it. PAHO's director will be summing up the epidemiological situation here in the Americas and will also address some steps to be implemented by the countries as part of the response to the epidemic. With Dr. Etienne, we have here today Dr. Jarbas Barbosa, Assistant Director of the organization, Dr. Ciro Ugarte, Director of Health Emergencies, and Dr. Sylvain Aldiguieri, who is the Incident Manager for COVID-19. Dr. Carissa Etienne, you have the floor.
Paulo Lira, and a very good morning to all of you and Happy New Year. Welcome to the first meeting, first media briefing for 2021. And PAHO is grateful to you for joining us once again. Since the start of this pandemic, over 39 million people across the Americas have become infected by COVID-19. And over 925,000 of them have succumbed to the virus. In the last week alone, 2.5 million people were infected with COVID-19 in our region, the highest weekly cases since the virus first reached our shores. Virtually every country in the Americas is seeing an acceleration in the virus's spread. In North America, the United States is reporting the highest new COVID-19 infections and deaths in our region. California and states across the American South have seen dramatic increases in COVID hospitalizations, with 13 states reporting record-breaking figures. Today, more than 132,000 are hospitalized from COVID-19 in the United States. These are more hospitalizations than during the pandemic peaks in the spring and the summer. These trends in hospitalizations are also being reported in Canada and Mexico, where the local health systems are struggling to keep up with demanding care. For the South and Central America, data from early January suggests that infections are on the rise in Costa Rica and Belize. However, it's too early to tell the impact of the holiday season on the virus's spread. So we are going to have to remain vigilant over the next few weeks. Across the Caribbean, data from early January reveals that many islands saw rapid rises in infections. The Cayman Islands, Dominica, and the Virgin Islands reported a doubling of cases within the last week alone. And cases are growing even more rapidly in Barbados, St. Vincent and the Grenadines, and Bonaire. And as we move to South America, every country has reported a rise in cases over the last few weeks, even in countries that had seen a decline in cases like Chile and Argentina. As our Southern Hemisphere experiences its summer months, many countries are struggling to limit gatherings and travel, which will most likely fuel infections for weeks and months to come. Scientists throughout the world and our region have also detected new variants of the COVID-19 virus. PAHO's molecular surveillance network spans some 21 laboratories throughout our vast region, and we are tracking the spread of the virus and mutations that naturally develop over time. So far, the variant first seen circulating in the United Kingdom has been reported in 6 countries in the Americas. At this time, there is no evidence to suggest that these variants affect patients differently, but early data does suggest that the virus can spread more easily, accelerating the threat to our health systems at a time in which they are already close to capacity. And that's why the public health measures that we've been urging from the start, such as practicing social distancing, wearing masks in public, and washing hands often, remain our very best bet to help control this virus right now in all of its forms. So let's look at the year ahead. Our collective ability to keep up with these measures has the power to determine the trajectory of this year. If we remain diligent, we have the power to control this virus. If we relax, make no mistake, 2021 could well be far worse than 2020. With one vaccine approved for use by the World Health Organization and more underway, we're moving closer to controlling this pandemic. A handful of countries in our region have already begun vaccinating health professionals, and a few have already started protecting other particularly vulnerable populations, like the elderly and those with underlying conditions. However, as long as doses remain limited, we cannot rely on vaccinations to flatten the pandemic curve. As we look ahead to 2021, I would say that there are 3 priorities that are critical to controlling this pandemic in our region. The first is to ensure equitable access to the tools, both new and old, to prevent and treat COVID-19. We must ensure that health workers have the protective gear and equipment that they need to do their job safely, and that every person who requires hospitalization can access the basic medications they need, ICU beds if that is necessary, to manage and treat the conditions. This is especially challenging as cases surge and supply chains are strained. With the arrival of vaccines, we must ensure not just that doses are produced quickly, but they are equitably delivered and swiftly across every country, regardless of income. This will require global and regional collaboration and solidarity, with donors pitching in resources through mechanisms like the COVAX facility. Second, we need leaders to act quickly and foster unity. This pandemic has taught us time and time again that leadership determines the effectiveness of a country's response. As we look to the year ahead, leaders will face difficult choices as we work to flatten the transmission curve. And that's why we need leaders to act transparently so that the public understands their decisions and the scientific evidence that is behind those decisions, so we can rally people around a shared plan. We need leaders to act in the interest of public health, not political gain, by working together to make the best use of the tools to prevent this virus. Politicizing vaccines and other control measures is not just unhelpful, but it could fuel the virus and cost lives. And finally, we must balance urgency with good planning. We don't have much time to lose, but we cannot beat the pandemic without strong vaccine delivery plans. And that's why PAHO is working with every country in our region to help secure the vaccine doses that countries need to protect their populations. We're also providing support with vaccine demand planning, logistics and cold chain management, surveillance and information system strengthening, health worker training, and vaccine communication planning, among others. Luckily, our region has a strong legacy of immunization and the mounting of immunization campaigns. Thanks to vaccination and surveillance efforts, the region of the America was the first in the world to eliminate smallpox, polio, rubella, congenital rubella syndrome, and measles. For 42 years, PAHO's immunization program has helped countries across the Americas work together to protect people against vaccine-preventable diseases. Through our revolving fund, member states pool their national resources to procure vaccines and related products at the lowest price. COVID will be a challenge, but one I believe that we can meet by working together. Over.
Thank you so much, Dr. Etienne, for these opening words. The first question we got from the journalists, in fact, we got this same question from so many journalists that I'm not able to mention all the names of all the journalists who asked. I put a composite question here. So the question is, the vaccination process against COVID-19 is quite slow in the United States as well as in other countries. How are the vaccination campaigns in our region? What can countries do differently so that more people are vaccinated in a short time? Dr. Etienne?
Thank you for this question. So let's just reiterate that already a few countries in our region have started vaccination, albeit with limited doses and having to prioritize the more vulnerable population, including healthcare workers. Now, we need to understand that the availability of the vaccine in the early days would be limited, given manufacturing and distribution timelines, and of course, because some high-income countries have already bought millions and millions of doses. So I think that the next 2 years are going to be critical, as vaccination of a majority of the population will not happen overnight. And I think we have to manage those expectations. If there are not enough vaccines to stop the transmission, then our initial strategy must be to use those vaccines to save lives by prioritizing those at higher risk. And this is precisely why the COVAX facility was created by WHO and its partners. And the COVAX is working to ensure that countries have equal access to safe and efficacious COVID-19 vaccines, and that it doesn't take them a whole year or more to be able to access vaccines. So COVAX is going to offer vaccines, access to a basket of some 15 vaccines. And we believe that distribution will begin by the end of March, and it will target at least 20% of the population with a focus on vulnerable groups. The situation should also improve once more vaccines are approved by national regulatory authorities. And these include vaccines that have already completed phase 3 and are in clinical trials. Today, we have a pipeline of more than 190 vaccine candidates. We're not sure that all of them are going to be approved, but it is encouraging to see that so many vaccines are in development. So working as quickly as possible, scientists from across the world are collaborating and innovating to bring us tests and treatments, but also vaccines. So We are hopeful. We need to plan very well. We need to use this interim period to make sure that every country is ready. And we need to begin the prioritization process because we won't have all the vaccines that we need immediately, but from March, we should begin to receive some vaccines. Thank you very much.
Many thanks, Dr. Etienne. The next question is a question from Gisela Salomon from the Associated Press. Can you please go ahead, Gisela?
¿Me escuchan?
Yes.
Okay. Thank you. Sobre COVAX.
Thank you very much. This is a question regarding COVAX. We would like to know whether you can offer us an update as to the amount of money that has been collected to purchase the vaccines in the region, and also how many vaccines will be secured with these funds, and whether you have signed agreements with laboratories, how many labs have signed those agreements, and when and where will you deliver the first doses? Because as we just heard from the directors, since some countries have already purchased through bilateral agreements the vaccines, we would like to know whether those agreements could risk the vaccines that are also available through COVAX for the poorer countries. Thank you very much, Gisela. Dr. Barbosa, could you please address this question? Yes, thank you for those questions. So let's look at the current situation with COVAX. COVAX, first, we have 10 countries out of the region that will be receiving the vaccine through COVAX without any sort of payment. Those would be countries that without COVAX would find it very challenging to receive the vaccine. There are other countries that we call self-financing countries. We have other 27 countries that are going through the self-financing fashion, and they are part of the payment for $436 million, and this accounts for 15% of the first COVAX phase, with the goal of vaccinating 20% of the population in each of the countries. There are some variations. Some countries have requested fewer vaccines, only for 10%, others for 16%, but the average is 20%. So that is the number. As to the process to receive the offers, COVAX by September 23rd, after receiving the offers, started to analyze the various proposals. We have 2 billion doses of the vaccines that have been secured for 2020. The difficulty is that most of those vaccines are being scheduled to be delivered in the second half of the year. For the first half of the year, COVAX by March will be delivering the vaccine, but with limited amounts, because that is what the producers are committed to doing with COVAX. We continue to negotiate with other producers. For example, it is quite likely that in February we are going to have a small amount of vaccines for some countries, and this will be sort of a pilot for about 1 million vaccines from Pfizer. And this is part of the negotiation, and certainly COVAX is also suggesting to use a platform for the developed countries that have already signed several agreements and that do have more vaccines than what they need for their own population, can use that COVAX platform, because the biggest goal for the platform is for the vaccine to be distributed with equity throughout the hemisphere. That is to say, we need to have enough vaccines for health workers and then also the other priority groups until we get to 20% of the population. That is the goal of the vaccine, to save lives and also to protect the most vulnerable individuals and the ones that have the most likelihood of dying due to COVID-19 infection.
We cannot hear you, Paulo.
Gracias, Dr. Barbosa.
Thank you, Dr. Barbosa. The next question is a follow-up question by Gisela Solomon. And this is also a question for Dr. Barbosa. Gisela, please, you have the floor. Yes, I would like to know how the vaccination process is working in the region. Could you give us some details as to what countries would need further assistance? What are the mistakes? What are the obstacles observed in those that have already been vaccinated? And also, who are you vaccinating? And what is your view of the process? Thank you. Thank you very much for that question. There are some countries in the region that have started using the vaccine through various bilateral agreements. So Canada, the US, Mexico, Costa Rica, Chile, and Argentina. Those are the 6 countries that have started vaccination. The numbers being used are very limited because that is the situation in the world. When we hear that the country has started vaccination, people oftentimes believe that mass vaccination has started. That is not true. The country in the region that has the highest ratio of vaccination so far is the US, that is approaching 3% of its population, and 3% includes more or less healthcare workers. The other countries are below that percentage, below 1%. So they started vaccination, which is quite good, but with a very limited number. WHO is always highlighting the need to have technical assistance for the countries in terms of vaccination, so that at this point in time, it is not only necessary to have the vaccine, but we also need to have a strategy. We need to have trained health workers. We also need to have an assessment of the cold chains. We need to have the communications process ready for the population, for the priority groups. We also need to have strategies to vaccinate at the hospital level those healthcare workers. How can we get to the households where we have the elderly? So we do need to have a plan. All of the countries in the region are completing a self-assessment tool, and through this tool, we're also providing further technical assistance so that once they have the vaccine, they can develop a proper vaccination strategy.
Paulo, you're muted.
I'm very sorry. The next question comes from Julia from the Veja magazine in Brazil. Julia, are you there?
Yes, sorry. Can you hear me? Hello?
Yes, yes.
Okay. So I'd like to know what is whose opinion about the so-called vaccine passport. Like some countries and working places are studying to request or demand a proof of vaccination for COVID-19 so people can engage in public activities such as traveling abroad or going to concerts and things like that.
Dr. Aldigueri, por favor.
Yes, thank you for your question, Julia. At present, WHO is not recommending proof of vaccination against COVID-19 as a tool for introducing changes to the way people are engaging in non-essential occupational activities, in travels, in religious and in cultural activities. In the context of a global limited vaccine supply and limitation on accessing the vaccine, there are challenges related to the logistics of the distribution of the vaccine, and we are in the middle of the pandemic. PAHO and WHO have set clear guidance for countries to prioritize the use of the COVID-19 vaccine that is becoming available to them. The top priority groups, as mentioned in many press conference and interviews at PAHO, the top priority groups for vaccination against COVID-19 are the healthcare, at this moment, the healthcare workers and the elderly. Additionally, at present, there is a lack of evidence on whether vaccination would reduce the risk of transmission of the SARS-CoV-2 virus. Therefore, at present, the introduction of requirements for vaccine passport or a vaccine passport is not justificable. It would fuel a false sense of security, and ultimately, it would have the potential to trigger the relaxation and adherence to personal protective measures, social distancing measures, and with possibly dramatic consequences on the dynamic of the transmission of the virus, as well as widening the inequities in health. At this moment, we would like to make a call to the public, but also to the local and national authorities and to the private sector and to the citizen to make an effort in understanding the current science behind vaccination efforts and to operate in a spirit of solidarity. We are at the very early days of the COVID-19 vaccine rollout deployment to the countries with long months ahead of us. And as of today, the imperatives are the following: to protect our healthcare workers and those suffering of highest mortality, and I mentioned already the elderly, and to continue with the adoption of the public health and protective measures for individuals and at community level. I hope I have answered your concerns and your questions. Over.
Thank you so much, Dr. Alighieri. The next question comes from Svet Lustig from the Lancet. Svet, can you hear us? Can you take the mic, please?
Hi, can you hear me?
Yes.
Thanks a lot for taking my question and Happy New Year. I have two questions. The first one is about the Russian and Chinese vaccines. Is there a front runner in terms of efficacy and safety given the availability of data?
Would you like to do all the questions, Svet?
Sure, with pleasure. And the second question is, to what extent have the Sputnik and Chinese vaccines brought hope to bring sufficient vaccines at an affordable price to the PAHO region, especially in light of potentially insufficient doses from COVAX? Have some of these countries in the region met the Chinese and Russian vaccines with resistance, more so than other vaccines from the West? Is there an estimate of how many doses have been bought so far for each vaccine for each country in the region of the Americas? Thanks a lot.
Thank you, Steve. Dr. Barbosa, if you can please take this question. If you need us to repeat, we will do that, but hopefully you were able to capture all the questions. Thank you. Go ahead, Dr. Barbosa.
Okay, thank you, Svet, or Svit, for the question. Look, it's very important to clarify that we have some countries that have bilateral agreements. This is their decision. We are not involved in any kind of bilateral agreements for any country. We are providing technical cooperation to establish solid national immunization plans. We are providing technical cooperation on regulatory aspects, but the decision to make a bilateral agreement and to purchase a vaccine, it's only for each country. What we are working is to strengthen the COVAX platform. For the COVAX mechanism, a producer, they need to fulfill some requirements. One of them is to be pre-qualified or to receive emergency use license from WTO. Now, we have only one producer that has received this pre-qualification or emergency use license, that is Pfizer. Probably the Moderna vaccine will be the second one in a couple of days, and the AstraZeneca is also providing all the documentation to be the third. Both producers, Gamaleya Institute, that is the producer of Sputnik, and Sinovac, that is the producer of CoronaVac, started the negotiation with WTO pre-qualification team. They will share documentations, they will share the dossier, the data about the clinical trial phase 1, 2, 3, all the information that is required. We only can say something about these vaccines when we review this data. Before that, we cannot say, from our point of view, we cannot say nothing based on press releases from the producers. We are waiting for them to provide this documentation. It's very important that they are interested to participate in COVAX. Every producer is welcome to COVAX, and they need to offer this data so the pre-qualification team can review them very carefully and approve their use. Until then, we cannot say if the vaccine has a better or worse performance in the other vaccines. But again, all producers are welcome to participate in the COVAX, and all of them will need to fulfill this requirement. We have a conversation with more than 16, now see around 16 producers. And all of them will need to be assessed by exactly the same criteria. And we have, as I mentioned before, we have already ensured around 2 billion doses for 2021 for COVAX facility and another 1.3 billion for 2022. But this is not enough, because this 2 billion will be enough to cover the first phase, to cover the 20% of the population. That is the first objective, and the aim in the first phase is to save lives. But we need to move it further and try to reach 70% of coverage in the population in order to achieve the control of the transmission. Thank you.
Thank you, Dr. Barbosa. Next, we have a question from Jacqueline Charles from the Miami Herald. Jacqueline, are you there?
Yes, hi, can you hear me?
Yes, thank you.
Yes, hi. I wanted to see what PAHO's reaction was to the CDC's requirement for travelers entering into the United States to be tested. We know in the region the testing is still controlled by a lot of health ministries. So is there any concern about the burden this will place in terms of COVID management and the ability of countries in the region to meet this requirement for individuals seeking to come into the US? Thank you.
Thank you, Jacqueline. Dr. Riccardi, can you please take this question?
Thank you, Paulo. Jacqueline, thank you for your question, because this is highly relevant for many countries in the Americas. Actually, PAHO has been providing guidance to member states starting in July 2020. And regarding that, PAHO does not support the use of testing as a tool to mitigate the impact of the spread of COVID-19. This is because of several reasons. One is the performance of the tests in the travelers' population, and also the related false sense of security that it generates, because as you know, the result of the test is accurate as the moment of the sample that has been taken, and it may change until the traveler initiates its journey. And also because of the operational implications, including the burden that the requirement of pre-departure tests result might pose on the countries of origin, but also on the countries of destination, and their potential to undermine response efforts on the countries of origin, but because resources could be diverted from other activities yielding greater public health impact. So the public health interventions are a priority and not necessarily the testing. PAHO considerations informed by a risk-based approach for each member state for resuming non-essential international travel were reiterated in a set of documents published also by WHO in mid-December 2020, so a few weeks ago, stressing that the antigen rapid detection tests are not to be used in the traveler population. That since several countries are basing the resuming of international traffic around laboratory testing, PCR would have some public health impact if performed upon arrival. However, the emergence of SARS-CoV-2 variants might also make the use of these tests even less cost-effective. So reiterating that the most important approach is to limit transmission and implement public health interventions in both the countries of origin and countries of destination. Thank you.
Many thanks, Dr. Ugarte. Next, we have a question from the New York Times from Sofia Villamil. And the question is in Spanish. I'm going to read in Spanish. ¿En qué 6 países está la nueva cepa de...
There are 6 countries where the new strain is found. So what is being done by PAHO to mitigate this situation? Dr. Alighieri, thank you very much for your question in Spanish from the New York Times. What I would like first is to explain that there's a culture of collaboration among the national reference laboratories for respiratory viruses in the region of the Americas. They work in a very active network. And today, 80,000 isolates of a virus, 80,000, I repeat, have been sequenced in 31 countries and territories of the region. The second issue, the second point, which is important to recall, is that the evolution is very quick in detection. So say at 10 a.m., we have 8 countries. At 10 a.m. today, 8 countries have reported the variant, detected it and characterized it in Great Britain in the region of the Americas. And these are Brazil, Canada, Chile, Ecuador, Jamaica, Mexico, Peru, and the United States. And 2 countries in the region have detected in their samples, in their laboratory samples, the variant which was characterized in South Africa, and these are in Brazil and Canada. So we want to encourage the countries to increase their level of alertness and share with regional reference laboratories, and we have several of those, the Public Health Institute of Chile, the Fiocruz Institute in Brazil, CDCs in the United States, and others. They can share samples in order to characterize the samples when the country does not have the facility to do it. In terms of public health measures, the measures are the same. Strict implementation of public health measures that uh, are included in the list of actions and measures that national health agencies have established. But the most important thing in these terms is evaluating what is going on in the dynamic. So when a country suspects or has confirmed the presence of a variant of COVID, of the virus, it is important to compare the proportion of samples that are characterized as a variant of the virus and which have another dynamic and the epidemiology data. In other words, we need to observe the dynamics at local level, at subnational level, at national level, and you compare it with the presence of the new variants within the country. And I hope I have answered your question from the New York Times. Over. Thank you very much, Dr. Alighieri. There is another question from the New York Times, also in Spanish. Why in Colombia has vaccination not started and we do not have a date for initiation of vaccination there? Thank you. Thank you very much for your question. Look, there are two ways in which the countries can have access to the vaccine. On the one hand, countries that entered into bilateral agreements, and these are decisions of each country related to their budget, to their capacity to buy vaccine. And so that's their decision approved by their local regulatory authorities. But then the other pathway is through COVAX. As I said before, COVAX from last year has the same timeline. We're going to begin to deliver vaccines in March, and we're going to begin with a limited amount with all countries that have access to the vaccine today. They still have limited amounts. The producers are beginning to manufacture, and they will increase manufacturing, and the vaccine will be more available in the second half of the year. But at COVAX, our expectation is that in March we will begin to deliver vaccines to all the countries that have joined the facility of COVAX. Also, with the limited amount of vaccines, transmission won't change. And the director just remarked at the beginning that the characteristic of transmission won't change for several months. And in order to be able to change the dynamics of transmission, we need to reach a vaccination coverage of about 70% of the population. And therefore, it is important that both countries who already started with a limited amount but have already started, as well as countries that we will begin to receive the vaccine in March through COVAX. The recommendation is the same. You need to continue to maintain all the measures that we know are effective in order to prevent transmission, to use masks, wear masks, to maintain physical distance from other people, prevent crowds. All these measures need to be kept and to continue for many months in all the world. These are the measures that are going to protect people in order to avoid getting COVID-19. Thank you very much, Dr. Barbosa. And now Gisela Salomon has a question as a follow-up. Yes, please, Gisela. Can you hear me? This question is about Brazil. The health ministry in Brazil made an agreement for buying and selling 40 million syringes, and the delivery should start this month, according to O Globo. When will this delivery be completed? Then a delay of 3 months was reported. Why did this delay occur? Dr. Barbosa, could you answer this question? Yes, thank you for your question. PAHO has the vaccine revolving fund, which is a facility which we've had for over 40 years in the region. This facility purchases all the vaccines for many countries in the region. And for example, for Brazil, in the year 2019, the vaccination against measles was done through the revolving fund. Brazil is an important participant in the revolving fund. The countries on their own can also buy syringes according or through the revolving fund. 5 countries have already requested purchasing syringes through the revolving fund. As part of the process, the country applies, and then PAHO enters in negotiations with those that have been approved, and then PAHO delivers to the Ministry of Health in that country the amount, and they tell them the dates, and the country then makes a decision. So there's an order from Brazil for 40 million syringes that are going to be delivered between March and April, and the decision about finishing the purchase, that decision is made by the Ministry of Health. We facilitate the process so that the countries can have more conditions of having these purchases in their immunization programs. Since Brazil is a federative nation, they buy syringes for vaccination at subnational level, and there are many different pathways, different routes through which countries can have access to syringes. And as I said before, it's not enough to have the vaccine. You also have the whole infrastructure. You have to have all the other things that are needed for vaccination so that vaccination can effectively be carried out, and that there is access to this great benefit, which is to have a vaccine available. Thank you, Dr. Barbosa. A follow-up from a country, Lidia Lopez from La Prensa in Nicaragua asks, regarding vaccination in Nicaragua, do we know when the distribution will begin? Have the authorities submitted a vaccination plan? Dr. Ugarte. Yes, thank you. Regarding vaccination, Dr. Jarbas could better answer the question. However, we have been in close contact with the government of Nicaragua, and the support to the immunization program from the standpoint of planning and operational aspects in the end is quite advanced. Nicaragua has an immunization program which is quite significant. And now over to Dr. Jarba so that he can complement regarding the COVID-19 vaccine for Nicaragua. Yes, thank you, Ciro. Just to supplement what you said, there are some reports in the media that Nicaragua is negotiating with the Camarilla Institute, which is the producer of the Sputnik vaccine. And this is a decision of each country. The regulatory authority in Nicaragua will make a decision. Regarding COVAX, Nicaragua is like all the other countries in that timeline to begin in March. And this is the difference between COVAX and others, so that all countries can have access at the same time. There won't be preference for one country or another. All countries will receive the amount of vaccine that is available, and it is going to be distributed equitably to the country. So our expectation is that in March, we will begin distribution of vaccines through the COVAX facility. Thank you. Thank you very much, Dr. Barbosa. The next question is from Kari Robinson from the Sunday Cleaner in Jamaica, and it is in English.
After almost a year battling COVID-19, the Jamaican government has only so far approved 8 testing labs to do PCR and antigen tests locally. The government claims it is awaiting PAHO's partnership to do more sites and cannot move any speedier than PAHO allows. What is causing a delay in testing labs being approved by PAHO? Can you explain the approval process? What are the implications if the government does not wait for PAHO? Dr. Alighieri, por favor.
Thank you for this question from Jamaica. First, I'd like to highlight that Pan American Health Organization and the Ministry of Health of Jamaica and the University of West Indies had a very close collaboration since the beginning of the pandemic. By the end of February 2020, there were 2 references lab set up, trained and equipped in Jamaica at the National Public Health Lab and at the University of the West Indies. And step by step, the Ministry of Health has expanded the network of PCR laboratories. The most important aspects that I'd like to highlight is first that in terms of reagents, through donations and through the access to the PAHO Strategic Fund, reagents can be procured and deployed to countries, including to Jamaica. So it's also a source of equipment and reagents that countries have the option to activate. The second important aspect is really the game changer that we have been working very closely with the countries starting September, which is the expansion of the laboratory network at the subnational level using antigen detection rapid diagnostic test. And we have deployed to Jamaica through donations this rapid test detecting antigens that allow the local level to characterize almost immediately symptomatic patients. And but there is also an access through the PAHO Strategic Fund to the procurement on the international market and the rapid deployment to the countries of this test. So really, the PAHO response team, including the virology team, is ready 24/7, even for training virtually and for deployments of personnel to assist directly. This is what was done with Jamaica, and we will be ready in the coming months to keep providing direct technical assistance and deploying kits to the countries, including in Jamaica. Thank you.
Estás en mudo, Paulo.
I'm sorry for that. This is the new year. I'm still catching up. So the next question was also asked for many journalists, and it goes like, why does access to vaccine vary so widely among the countries of the Americas? Dr. Etienne, please.
So let me thank you for this question. And this has caused significant stress among some of our member states. Let's face it, inequity is a reality of the world that we live in. And certainly in our region, you've heard it quoted that inequity continues in our region. And in our region, we see inequity along the lines of people living in poverty, along gender lines, along lines of populations in conditions of vulnerability. And that same inequity persists, even when we are dealing with vaccine access. One of the things that we've seen is many countries making individual deals with pharmaceutical companies for vaccines. Most of those countries globally have been high-income countries, and some of them have bought many times more than they need with different producers and manufacturers. So this a lot depends on their ability, on their budgets and their ability to pay. For PAHO, this is extremely important. We've been at the forefront of addressing health inequalities and inequities in the region. I mean, we must recall that from early January, mid-January, we sent information to all countries last year, informing them about the the emergence of COVID-19, which was not COVID-19 then, had not been named. But also importantly, we ensured that all countries in the region had access to tests. We made tests available and training for all of our countries. So by the end of February, most countries had this. So we worked against the inequity there. We also ensured that all of our countries had supplies of PPEs, emergency supplies of PPEs, and some of the other equipment that they needed. So we worked swiftly across every country. And we did that irrespective of income. But importantly, with vaccines, we know, as I said before, that there are not sufficient doses available now. Manufacturers are still producing. Many countries have bought really large quantities of vaccine doses. So it will take some time for those doses to reach some of our countries. A few of our countries made their bilateral arrangements with manufacturers, and they have received limited doses. I think what's important for us to know is that through COVAX, we have addressed some of that inequity in ensuring that all countries, particularly our low-income countries and middle-income countries, will have access to some vaccines. There is history. For H1N1, our member states did not receive vaccines until 10 months to 1 year afterwards. And this is what COVAX is addressing: equitable access, equitable early access to vaccines. So this leads me to a final point. Until we have sufficient doses, until we are able to immunize or vaccinate 70% or more of all of our populations, we must continue with the public health measures. And those public health measures are what is going to guarantee us to be able to reduce the spread of the virus. We need to ensure that we detect cases, that we isolate, quarantine, that we are able to communicate with our population. We need to ensure that we do not congregate. We need to ensure that we socially distance, that we wear masks, that you wash hands frequently. Those are the things that are going now in this era to allow us to be able to prevent the wide transmission of the virus. While at the same time we work with COVAX, we work with our member states to ensure access to vaccines, but importantly as well, to ensure that they are well prepared once they receive the vaccine to distribute the vaccine first to priority groups, healthcare workers, first responders, the elderly, those with underlying conditions, and then as vaccines become more available to the rest of the population. So thank you very much again for being with us.
Many thanks, Dr. Etienne. Gracias a ustedes todos y todas por participar.
Thank you very much all for having participated in this press briefing. This is the end of our briefing. If we didn't answer all your questions, we will make sure we will follow up. All of you can send additional questions to media team at PAHO.org. You can also obtain more information on PAHO's response to COVID-19 epidemic on our website, www.paho.org. And thank you very much. Have a great week, and we'll see you next week. Goodbye.